session. Dr. Bhakti is head in clinical anesthesia at TMC ATRAC and academic in charge of ATRAC Center. She is a GC member of ISA Mumbai Metro branch. So I invite Dr. Bhakti to take over the proceedings.
Good evening, everybody. Thank you very much, Yogita. We are going to have a different session today, and with great pleasure, I would like to invite Dr. Snehal Kade, who is a senior clinical fellow at the Barnet and Chase Farm Hospitals, Royal Free, London, NHS Foundation Trust, to talk to us on newer teaching modalities for the Gen Z. Over to you, Snehal.
Thank you. Thank you so much. I'm just sharing my screen a minute. Thank you. All right. I hope everyone can see the screen. Is that okay?
Yes, it's visible. You are audible also.
Perfect. All right. Good evening, everyone. It's my great pleasure that I'm actually presenting this topic, innovating teaching modalities for Generation Z. So, let me just start right with the topic. Now, Generation Z, as colloquially they're called as Zoomers, have been born between 1997 and 2012. There's going to be a discussion about whether they're born in 1996, 1995, but the fact is that they're characterized by digital nativism, and they have a preference for interactive learning experience. Now, this is the demographic cohort which has succeeded the millennials. So I'm a millennial, Generation Y, and they are preceding Generation Alpha, which is the next generation beyond this. What is the characteristic of Generation Z? Now, these are these really tech-savvy who seek instant gratification, and they prefer visual and interactive content over traditional methods. And why is it so important for us as educators to try and understand Generation Z in general? And that is because we need to sort of create more engaging experiences for them. They have very unique preferences. They have their unique learning styles. And it's pretty challenging as such to teach them, more so because there's the generation of internet, where COVID-19 pandemic hit, the political aftermath of it all, and the substantial online education content that they have been all exposed to. Starting with the very basic traditional teaching method, which is basically the lecture-based approaches and the hands-on training. Now, I think at the very onset, I would like to explain that these very core methods are the very foundation of medical education, which provide theoretical knowledge and practical skills. So when I say lecture-based approach, it's basically anesthesia education being delivered in a theoretical knowledge in a very structured format. And hands-on training is what we do daily in theaters, in ICU setting, in emergency department, where you're applying the theoretical knowledge to practical scenarios. Now, what exactly are the barrier to traditional teaching methods? As we all know, sometimes these can be very passive sort of learning experiences. There can be sort of limited interaction between the student and the educator. And sometimes the need for continuous innovation to meet the need of modern learners can sometimes be a bit lost. So what do we do really to improve? Now, we continue with our traditional teaching methods, which includes even lecture-based learning. But what we could probably do is involve infographics, which is, so this is a generation that's known for visual hunger. And just visually structuring your entire learning material can actually make it much easier for them to sort of grasp the required knowledge. Of course, it can be very challenging, but a very rewarding task at the end of the day, because it increases student satisfaction. And what's been generally seen is that it gives them more visible clues to the important things, and they are able to retain the information much better. Apart from the traditional methods, simulation exercises. Now, simulation is a technique to replace real-life patient experiences with guided experiences. And you're basically replicating substantial aspect of a real world in a very fully interactive manner. Now, as an anesthetist or an intensivist, we often come across a lot of life-threatening events. And you need to sort of carry out multiple tasks simultaneously. Similarly, anesthetists are also involved in rapidly evolving clinical situations, and you need to regularly sort of make appropriate decisions. You need to have adequate communication skills within the entire team in theaters or even within the intensive care unit. And various non-technical aspects of an anesthetist's day-to-day work can be sort of simulated in this process of simulation exercise. So it can be as simple as using a human airway model to teach airway skills, or a sim man for cardiac arrest situation. And the fact that these are all very standardized scenarios that have been built, and it actually gives you a feedback, especially the sim man, it's known to give you a active feedback at that very point. So it's a very helpful tool to learn and even for your assessment of competency. Revolutionizing anesthesia training for Generation Z learners with mobile phone applications to support learning. Now, at this point of time, I'll just like to know whether all of us use different kind of apps. If anyone can just tell me if any of them have been using any sort of mobile apps on their phones on a regular basis. Anyone?
Yeah, Medscape we are using quite often.
Right. Okay, so thank you for that. So basically, what I've found out is that a lot of the Generation Z are very used to these kind of mobile apps on their phone. And believe me, they're very user-friendly. They're actually really helpful. Some of these apps like MedCalc, Calculator, and Medscape is actually completely free. So it's pretty helpful. And I'm just giving a small and a quick example to actually show how that works. Now, if I don't know if all of you can see, this is the Med Calculator app that I've just opened up. It tells you whether you can actually choose anesthesia as your specialty. There are different other specialties that you can opt for. And on your mobile, it actually tells you what is your creatinine clearance using Cockcroft-Gault formula. Now, the formula is not very intuitive. You end up forgetting a couple of things. But even if you just click on creatinine clearance, it tells you every step of the way what you need to do, whether you need to put the sex of the patient, the age, the weight, the creatinine. It even gives you an option. For example, some countries provide creatinine in milligram per deciliter, while others provide it in micromoles per liter. And you have an option of changing that. And once you've set in whatever the required sort of inputs, it gives you the next step and tells you and advises you so as to what is your creatinine clearance. It clearly tells you what are your pitfalls, whether it is your of the fact that yes, this formula is overestimating your EGFR. But I think the app is very user friendly, and I personally would definitely recommend it. It's really helpful. So even when I have to find out the APFL score for a patient to calculate my post-op nausea, vomiting, or so all of these are sort of readily available over here. I in fact have a few favorites because I actually end up using them quite a lot. So whether it is Duke Activity Status Index, whether it is Revised Cardiac Risk Index, which we often do in our preoperative assessment. And now with a lot of medical legal sort of issues propping up, it's really important that you perform risk stratification of all your patients beforehand. So I personally do recommend a lot of these apps, and Generation Z are the ones who have been using these apps regularly, and we as educators need to learn about them. Medscape also personally is very helpful, apart from telling you about a lot of medical conditions, drugs and diseases, which are a little rare. I've personally found a very important feature in Medscape that's really helpful, which I'll just like to share. So if you open your Medscape app, it has an option of something called as drug interaction. And you actually, so often we come across really old age patients who have like 10 or 12 drugs being given to them. So on the drug interaction aspect, if you actually put all of those 10 drugs, it tells you what are the different drug interactions that they have. So what I'm trying to say is that these kind of mobile apps, which are often used by the Generation Z, is something that as educators, we need to learn and we need to educate ourselves. Of course, there are other methods like interactive technology, gamification, virtual reality, all of which are now coming up. Interactive technology, now personally, we haven't been using a lot of virtual reality and interactive technology, but moving forwards, that's going to be something that's going to be coming up more and more. And what they've shown is that virtual reality-based learning can improve retention rates by up to 80% compared to traditional methods, making it a very powerful tool for enhancing knowledge and retention in anesthesia training. Of course, all of this comes with caveats. So what I'm trying to say over here is that basically, you will, even with virtual reality, you can offer them realistic and hands-on experience in anesthesia training. But you won't be able to learn to deal with emotional situations in virtual reality. The fact that you won't be able to be empathetic towards your patient, to be able to manage your own emotions. And these complex set of behavior can only be guided through a series of real life situation with careful guidance and mentoring. For example, even the importance of debrief after a critical incident. I think it's really important um, as educators for us to realize that face to face education has also never been as important as it is today in times of virtual realities. And because Generation Z or Zoomers are known to suffer from a lot of mental disorders, high frequency of anxiety, sleep and attention deficit disorder, I think this sort of digitally savvy and generation needs the kind of emotional support, and you need to manage their expectations and setbacks. So that's again something. In spite of all the things that we've mentioned, there are going to be caveats, and as educators, you need to manage, you need to mentor them towards these situations as well. So, what I'm trying to say over here is blended learning experience. You do not leave behind your traditional methods, but at the same time, you involve the other aspects, like I said, the mobile apps. You need to sort of educate yourself on that. You need to learn about the different simulation techniques, because moving forward, I've personally found simulation techniques extremely helpful, because you can actually learn all the non-technical aspects of how to deal with a critical situation. The fact that you need to now move towards personalizing education and various other different adaptive methods. So, blended learning combines in person instruction with online resources, increasing flexibility and accessibility for Generation Z learners, along with app support and other innovative techniques to drive retention. Over here, I'll just like to mention something about remote learning opportunities, because I think e-learning or virtual classrooms have evolved a lot, especially during the COVID pandemic. And they have actually fostered a lot of flexibility and convenience in learning anesthesia techniques. E-learning and learning management systems have used organized learning resources, and they've been very helpful during the entire pandemic. But what we need to do is we need to make it as engaging, as interactive as possible, because that just basically increases the learner's satisfaction. Personalized learning tailors education to individual preferences and needs. Now, I do realize sometimes it can be a bit challenging for a teacher to actually have personalized learning for every individual. But what we've really seen is that most teachers do believe that personalized learning improves student access by increasing student engagement and higher achievement levels and better retention rates. Adaptive methods is basically, again, pretty much like personalized, where you adjust to the student's needs and progress, and you can significantly increase student performance. Now, in the middle of all of this, it's very important for us to understand continuous professional development, which basically means that as educators, we need to continuously train ourselves. We need to update our teaching methodologies and technologies. You need to improve the delivery of anesthesia technique instructions to Generation Z. So teaching the trainers is something that is sort of a mandatory skill, just so that we are able to cater to the needs, the educational needs of Generation Z. So, what exactly is the future trend in Generation Z education? A shift towards artificial intelligence, machine learning is revolutionizing education for them, offering personalized learning experiences and enhancing outcomes in anesthesia training. And these AI algorithms and machine learning is going to optimize educational content delivery. And the fact that a lot of times the sim man, for example, that we've used in adult life support situations, it actually provides you a real-time feedback, wherein every step that you take after it sort of has given you, it gives you real-time feedback. And I think that's really helpful. And it helps the students to adapt and understand and learn along the way. Enhancing personalization, improving student outcome, and data-driven insight are some of the key advantages of AI integration in education. So I think what my key take-home message is that Generation Z is now the newest generation of health professional students who are going to be entering the classroom. They are a generation that has been basically influenced by the boom of social media and widespread internet availability. and there's a lot of decreased face-to-face interaction. So we stick to our traditional methods, modify them, make it more interactive, have more infographics, involve simulation, learn about the different app techniques, different mobile apps, learn about how do you cater to e-learning, e-books, virtual classrooms, learn about virtual reality sessions and artificial intelligence and simulations. So basically, have a more blended learning experience, have a more sort of personalized learning experience for the Gen Z. And yeah, moving forward, I think that's what we need to do. Thank you.
Thank you, Snehal.
Thank you.
Himaja, do you want to go next? So we have four of our fresh graduates here: Himaja Nara, Minal Bicheva, Yogita Agarwal, and Chandani Rana. Let's see what they have to say.
Hello, everyone. Am I audible now?
Yes, you are, Yogita.
Uh, so we will be talking on how to reach a Gen Z. So though I take a immense pride in being a millennial, we now be talking to how to reach a Gen Z. So right now, how Snehal ma'am said it, that we have to take a integrated and blended method. So since we were studying for our exam, we had taken a help of computers, mobiles, online materials. Though we had the best interactive case presentation sessions in KM from the best teachers, but still we had taken the help from online materials also. So that's how Gen Zs are. They will be needing a blended approach. They want everything short but sweet. Why? Because they get bored easily. So they will need short courses, more engaging, more interactive, and it should be at their own pace. Because whatever we try to do, we have to understand is what is their level. So this was this one one study done in Tata Memorial where it was asked that if MD curriculum should have any modification. So these were some responses which have been got. So they have told that it should be more interactive session, short answers, OSCE type, MCQ situation based, more face to face classes and seminars. Another thing is ki they want some cool gadgets, like as ma'am was saying ki smartphones, online softwares to take notes, or there should be fun quizzes, games, or a simulation workshops or learning lectures where they get a personalized training, because they like to learn from what they see or what they do. They don't want that didactic lectures which used to happen in ancient time. They will get bored of them. We can have, so because they are very pro to the social media, so we can get used to we can take help of that. So whatever we feel is not good is actually cool for them. Over to you, Himja, now. Okay, step 3 is how to befriend them. So they preferred a personalized training, as I was saying.
No.
They would like to.
Can you hear me?
Hello?
Hello, can you hear me?
Yeah, you are audible.
Yeah, ma'am, I can. Yeah. Should I go ahead? Am I audible?
Yes, yes.
Hello? Am I audible, ma'am?
Yes, yeah, go ahead.
Okay, thank you. So I was saying, step 3, as I was telling, it is like befriending them. You can't be like always asking them or telling them. You have to sometimes listen to them because they have their own ideas, methods, how to do things. So we would like to sometimes take their idea in person also. So each day you have to got a new method, new experimental thing, because they will get bored if you keep doing same thing with them. And they would like to have some collaborative online programs where they could make a group project, or they'd like to be in a group where they feel that they are same kind of people. So again, this is the part of that study which was done in TMH, and there they have saying like this only, कि they want more skill based training, more practical approach, clinical scenario based. So they would like that. So as I said, you got to vibe with them more than just teach. So that was our perspective in how to reach Gen Z.
Yeah, thanks all of y'all. I think
Ma'am,
that's. Can
before
you?
this.
Can you hear me?
Yes.
Yes, ma'am, we can hear. So should Chandni and all continue after the next session about the remaining
Yeah.
part?
Yeah, so there is maybe we can take a couple of questions here regarding the teaching methods. Thanks all of y'all for collating what you would want or how you would want us to teach you. We obviously where we when we learned, it was more from observation, hands-on training and didactic lectures. And things have changed, especially post COVID, as you rightly put in, and Gen Z or the Zoomers have a different way, and this is our effort to reach them so that there is more effective teaching, learning on both sides. So there's somebody who has said, are there different methods of assessment? Uh, so currently, at least in India, we haven't graduated, but from what I understand, a lot of universities abroad, Snehal, you could correct me, have taken into account simulation-based assessment programs. Uh, do you want to enlighten us on that? And
Yeah, I think I completely second that. Like you mentioned, and as I mentioned even in my presentation, I think because of the fact that with simulation there's a chance of feedback. Like SimMan actually gives you feedback when you have an ALS situation. I think that sort of is another method of assessment of your competency. Even when we go for our ALS training, at the very end you are given clinical scenarios wherein you're actually assessed on the basis of that. So yes, that moving forward, that's going to be one of the methods of assessment. And apart from that, I think my colleague over here did mention about the Gen Z preferring things like OSCE sessions or MCQ sessions over the longer question answer sessions. I think moving forwards, this is what I think the Gen Z really wants to be assessed on. More on interactive sessions, more on simulation-based sessions, having OSCE, having these kind of Viva sessions, but at the same time, not having these long question-answer sessions for the assessment.
Yeah, Sachin, you want to say something?
Yeah, Bhakti, thanks. I've managed to find a space now. So apologies for the delay. I was listening though. What I wanted to add here is that simulation is used for assessment of the process, not the outcome. I think we got to be very clear that if in the simulation, if the particular trainee or whoever it is, the nurse, the outcome of the patient actually is not good, actually, if the patient, let's say, dies or they can't intubate, that doesn't mean that they failed the assessment. I think we got to be very clear that simulation is for teaching them or assessing the process. They should know the flow chart or whatever it is, protocols, rather than the outcome. So there's a little bit of difference there, unlike, other things where you look at the outcome. We don't look at the outcome, we look at the process, if it makes sense.
Yeah, that's true. And I think traditionally all the exams that are conducted, they just look at your thought process. I mean, we never have, though we have tables and vivas, and it's probably what the candidate
Correct.
says. They're not actually intubating, because for that, I mean, I don't think anything else can replace the skills but working in the OT. Anybody
Yeah,
else?
that's correct. Well, I think with simulation you can get the outcome. With other things you can't get the outcome, isn't it? With simulation you can kill the patient actually. So that's the difference. So got to be careful when you run a simulation session, because people do get fixated and people do get upset. We've seen that. They get really upset, and that's not the point of the exercise. They should go back with confidence and not with a broken heart, basically. So thanks.
Yeah, that's true. Okay, there's another question. Are there any standardized questionnaires on assessment of simulation? Sachin?
Sorry, what was the question?
Are there any standardized questionnaires on assessment of simulation?
Oh, you can do simulation for lots of things. And so, for example, airway simulation, if you go, I can send links where, and Bhakti knows actually, we do that at Tata actually. You do have, yes, absolutely. So, for example, when our new trainees come in, we make sure that they get to the ALS, via simulation or basic airway scenarios. And yes, they have to pass those bits. We have, yes, for most of them. And they should be available online, actually. It's not difficult. They're open resources for that.
Yes, that's true. Okay. If there are any other questions, maybe we can take them, or we can go to the next talk.
I guess we can proceed for next.
Yes, I think there's no more questions. So maybe we'll move forward. I would like to invite Dr. Sachin Prabhu. He is a consultant in anesthetics, divisional director, surgery and associate services, Barnet and Chase Farm Hospitals, Royal Free London NHS Foundation Trust, and of course he is a Mumbaiker to start with. Sachin, thank you very much. I know you are at the airport, but thanks a lot.
Thanks, Bhakti. I'm at the airport flying to Mumbai, which is very ironic.
Yes.
Anyway, Bhakti, thank you. Thanks for inviting both me and Snehal. Actually, we're very thrilled to be a part of this session. And thanks to all the organizers. You're doing a fantastic job. So if I can have that presentation up.
Yeah, sure. 1 minute.
Thank you. So I'm basically doing a talk on, the ask was crisis management on a clinical day. So what I've tried, it's a big topic and it's not as specific as that one. So what I've done is I've put 2 clinical scenarios in there, which one is a fairly uncommon scenario and one is not that uncommon. And then what I've done is I've touched a little bit upon various sort of things that we can improve as teams, as leaders, as doctors, as nurses, and a little bit about the framework that we have in the United Kingdom. And I think the framework in the United Kingdom is very developed in terms of safety and risk. So, I mean, the aim of this is to kind of educate people, but at the same time, with the hope that some of you will get hooked onto this the risk in critical incidents and hopefully inculcate that in your own hospitals, in your own practice. Thank you, Bhakti. Can everyone hear me clearly?
Yes, we can hear
Okay,
it.
lovely. Yeah, Bhakti, next slide. Thank you. So the first case, this is again a case which happened in our hospital. Actually, it's a elective cesarean section. A 33-year-old lady who had a history of placenta previa. I think you're running ahead, Bhakti.
Oh, sorry.
Placenta previa, polyhydramnios, and breach. She also had gestational diabetes, and there was a past medical history of viral pericarditis in 2017. But nothing to worry about. It was she's sort of posted for a section. Next slide, please. Again, standard practice: 2 large IV bore cannulas, blood cross match, a combined spinal epidural was done, and there were no issues with that. Pretty straightforward. Tranexamic acid was given as requested by the team. Her blood pressure is slightly low at the start. So, as standard practice in the United Kingdom, we normally start some phenylephrine infusion. Blood pressure is picked up clearly to maintain placental perfusion, as all of you would know. Standard sort of marking with bupivacaine, epidural catheter inserted. She was quite stable with the phenylephrine infusion. Block was at T3. Everything sort of hunky-dory at this stage. We normally have the partner or the husband next to the patient, actually. So in this case as well, we did have somebody there. So the next slide is just the blood pressure. It's a snapshot of the blood pressure in the monitor, and that looks actually fine. There's no issue with that. Next slide, please. So once she starts, it's not uncommon for patients to complain about discomfort when the baby is being delivered. So the usual things were done. She was reassured because the level was good. Healthy baby was delivered. There was no bleeding, blood pressure. Well, after the baby was delivered, there was a drop in blood pressure. Very common differential diagnosis. You think about a high spinal, so on and so forth. Phenylephrine boluses and ephedrine was given. She then started complaining difficulty in breathing, and there was a decrease in consciousness. And that's obviously is a bit more than what you would normally expect. And as you can see on the screen, or you may not see actually, but the blood pressure is in the boots right now. It's sort of, quite low. Next slide, please. So this was a trainee anesthetist, a senior one. He called the consultant who was just next to us. We got 5 theaters next to each other. So within seconds, a consultant came in, and as you would normally just put some oxygen up, bring the blood pressure up, atropine. Because the blood pressure didn't come up, some adrenaline was given, and this slowly sort of moved into the next phase of basically a PE arrest, actually. Next slide, please. So the area was secured, arrest call was sent. Again, in the UK, there's a arrest team in the hospital led by the medical registrar, usually. They turn up pretty quickly once the call goes. Patient was intubated. And again, as per the protocol, you rule out 4H, 4Ts. We do have a mechanical compression device, which was asked for because the CPR went on for quite some time in this lady, actually. We also have a peripheral sort of team which is called as PART, which helps with sick patients. Everybody turns up for this call, actually. So next slide, please. And this is a blood gas. I don't think whether you can see or not. I definitely can't see, but the pH is 7.221 in this one. And there's a progressive set of blood gases. The differential diagnosis at this stage, clearly either a high spinal, which was unlikely actually with such massive hemodynamic decompensation. But the commonest thing you would think is some kind of embolism. And in a lady who's delivering an amniotic fluid embolism probably is the one which you would sort of hedge your bet on. Next slide. Again, the blood gases start getting worse. They're like half an hour into the arrest scenario. Because she is a young lady, we contacted the ECMO team. Initially, they were not interested, but once the whole case was discussed, a decision was made that she could be transferred for an ECMO. But clearly, she was not in a position to do that. The third blood gas was even worse. I think the pH was 7.1, and I think the next few blood gases it gets even worse actually. So clearly, this is now going downhill, and after some time, she's not even fit for an ECMO. It's 10:52. I think we're like an hour and a half into the arrest scenario, and the decision was made to stop the resuscitation. So it's a very sad case actually. In my sort of 25 years career, I have never been involved in a cardiac arrest in an elective section. In emergency we do see, but for the first time, I mean, I was not in this case, but as a department actually. So it actually was quite depressing. It hurts. So the normal things we were done at the end of the case. There was a hot debrief, a swarm huddle. A swarm huddle means you basically get in people who are involved. In this case, the obs and gynae team, the anesthetic team, the nursing team, the HCAs, the ODP. So they all came, they sat together, and they spoke about what good things were done. Always talk about things which are good, actually, to start with, because nobody's in the mood to talk. Everybody talks about bad things. So talk about something, what positive we've done. And this was a great team effort, actually. Everybody had done what they were expected and went way above their capacity. Make sure the notes are written accurately, because this case will obviously go to the coroner. It might end up in a court of law. So you've got to make sure the notes are written and they match, especially with the timings. The duty of candor. Duty of candor means basically you have a conversation with the family member or the patient. In this case, unfortunately, the patient was no more. So it was important to have a conversation with the family member, and that needs to be done by a senior team, basically a consultant. So that needs to be done. A statement, when things are fresh in your mind, do write a statement, and we encourage that because you're fresh with all the information. A statement should be written as a statement of fact. It should not be an emotional statement. So never write emotional statements. Write statements of fact. Postmortem was requested, unfortunately was not done in this case for whatever reason. And an action after review, an AAR that's called. An action after action review basically again is the same thing. You bring the team together and you dwell into the depth of what went well, what could have done better, and some learning from there. And it's common in the United Kingdom that this is a maternal death, so it gets investigated by something called the HSIB, Health Safety Investigation Code, and that was what was done. So
Dr. Prabhu, I think you're not audible anymore.
Oh,
You've just,
can you hear me now? Okay.
Yes.
Thank you, Snail. So that was the first one. I think we'll come back to questions later on. The second case is something, again, I think that's probably a little bit, it's not common, but it's not uncommon either, actually. This is an 80-year-old gentleman who was posted for a DHS, which is for a fracture neck of femur on the right side. Again, this happened in our hospital a couple of years ago. Patient was going to have a right hemiarthroplasty, was consented for a right fascia iliaca block with a GA, and patient was a diabetic, so we put some insulin as a sliding scale. So they came with a pump effectively. On the ward, a preoperative check was done. So at least in our hospital and standard practice in the UK, when they leave the ward, there's a checklist. So they will check the patient's details, their date of birth, their name, their MRN number, and then consent, whether it's signed or not, whether it's the correct consent, if they've got dentures, if they've got implants, and so on and so forth. So that was done. Next slide, please. So now this was the second case on the list. The first case was also a hemiarthroplasty, but that was done on the other side. So this was the right, that was the left one. So everything in the theater was sort of kind of set up for the other side. When the patient was sent for, as an anesthetist, we have an assistant with us, which we call as the ODP or anesthetic nurse. So it's just like a Swiss cheese model. That particular nurse went for a break. So somebody just came to relieve them. So in the room, there was the anesthetist and the ODP actually, who did the normal checks, and we do W2 check again when the patient comes to theater. So as an anesthetist, I will always check my patient again. The same thing, the name, age, MRN, fasting, consent, side, and everything looked fine actually in this case. So monitoring was attached, and off they went. Next slide, please. So the anesthetist, again, this is the statement given by the anesthetist. As per the usual practice, the patient's cannula was checked because they came from a ward, fentanyl propofol given, airway secured, and a large bore cannula was inserted without any complications. Now, while the anesthetists now wanted to give a block, when they were preparing for a block, there was a distraction because the ODP was talking about his holiday, because he just come back from holiday. So again, you need to remember distractions are a huge part. As an anesthetist, we fail to realize that we work under such conditions and so much of commotion. You almost blank the whole thing. But if you were to observe somebody in theater, you will find that there are loads of distractions. And this is an example of one where the ODP was telling them about their holiday when they were doing the block. Next slide. So the positioning was done. During the positioning, now remember, this is a right-sided neck of femur. The left side of the patient was exposed. At the same time, the insulin pump started alarming, which distracted the anesthetist. So they kind of changed the rate or whatever it is, put the alarm off, and they went back to the block. Now everybody's forgotten this is the right-sided one, not the left-sided. The anesthetist then looked at the monitor to check that the patient was asleep, check the vitals, sprayed landmark, and then give the block with the needle. I think this is a two-pop technique rather than ultrasound. Aspirated and gave 30 mils of L-bupivacaine. And again, this was on the wrong side, actually. Once the block was administered, the patient was shifted to the theater. When they were positioning the patient on theater, the second nurse came back, the first ODP left, and she saw that actually there was a needle mark on the other side, and then brought it to the attention of the anesthetist. The anesthetist saw the right exposed leg with a surgical side marking, because the surgeons do mark the side, and realized that they had blocked the wrong leg. So it's a horrific feeling actually when you do that, and I'm sure this is not an uncommon scenario. It's rare, but it's not uncommon. Next slide, please. So what the anesthetist did here was she calculated the dose of the toxic dose, and then she put a block on the other side. The anesthetist followed the patient up in recovery. He was comfortable. His observation was stable. The patient's son, who was on site, was then contacted. So this is the duty of candor. You got to be honest with the family. You got to tell them what happened, and that is very important. And I'll come back to that as we move forward. Next slide, please. The investigations, key points. So this case was investigated through normal protocols, and the panel concluded that there were a lot of distractions and a significant amount of activity took place after signing in. And again, we spoke about the distractions. The ODP talked about the holiday, the insulin pump going off, a small anesthetic room, and so on and so forth. The other thing also they found was the stop before you block, the SBYB process in the trust policy. That was not done, actually. We have since introduced, and I'm sure it's there in most hospitals. I don't know what the audience here is. I think some of you may be coming from a private setup where you are an individual anesthetist, but stop before you block is a standard practice now. And not only that, now we put a stop, the poster on the anesthetic machine or the ultrasound machine as well. So before the needle goes in, you always stop, everything stops, and you check it's the right side or not. Next slide, please. Okay, so again, these are the two cases actually, just to give you a background of, we work in a very high risk industry. We know that healthcare, in the airline industry, about 80% of the incidents are because of human factors, but we actually don't know how many of those in the healthcare industry are. So we are a fairly rogue industry in that sense when it comes to data about human factors. And especially acute specialties like anesthesia, ED, it's even worse actually, because the environment is a fairly chaotic one. To deliver the safe medical care, again, we got to have good team strategies, and we'll come to that later on. Adverse event healthcare generally result of complex combination of human factors and system failure. Again, it comes back to the same human factors, and some system failures, which we need to work on. And lastly, the crisis resource management. We'll talk about it as we go forward. Again, the CRM basically started from the airline industry, where it was the crew resource management, and then slowly evolved into crisis. Now we've left the industry behind, and we got our own systems in place, which work really well actually. Our incidents have come down dramatically. And at least I have seen that in the last 20 odd years, where it has made a huge difference, much more safer. So what are the key elements of the crisis resource management? The first one is leadership. All of us are doctors. It doesn't have to be doctor, but when you are in theater, you have to act like a leader, because people look at the anesthetist, for comfort. You are a fairly calming influence. and you have to lead accordingly. Doesn't mean that you have to lead all the time. A good leader actually has to be a good team player as well. So team leaders are responsible for assigning specific roles. So, for example, in the rest scenario, the team leader, in this case, the medical registrar at that stage, would give specific roles to everyone. So, somebody for CPR, preferably you yourself should be hands-free so that you can then keep a helicopter view of what is happening actually. Okay, so, and that's what it says. Leaders should maintain the global view of the crisis and avoid fixating on isolated details. They should continually synthesize the information. Lots of information flows in actually, in a crisis. You should be able to sort of, filter that. And that's quite difficult actually, not easy. Leaders should look for feedback. So if somebody tells you, listen to them actually. Listening is an important part of leadership, whether it's in a crisis or outside a crisis. Listen, it makes a huge difference. Don't ignore. They should balance confidence and humility. Again, the word humility is very important. If you're a senior person, your junior will never approach you if they're scared of you. So make sure that you're approachable and they're comfortable to make that suggestion. That could be a very important suggestion which could save the patient's life. It is important to know that an effective leader requires an effective team. Again, if you're a good leader, you probably will build a good team around. And they should be, as I said, empowered to speak up. They should have the guts to speak up. So, next slide, please. The next is communication. Again, I'm not going to sort of, mull over this, but communication is very important. Make sure that one of the things which comes up in communication sometimes is actually important that you do a closed loop communication. What that means is if you tell somebody give, 100 milligrams of socks, then the person they should say given 100 milligrams of socks. So that's called as closed loop communication. Then the task is done and there's affirmation about the task. That's good practice actually. I like that in the airway scenario where I would want to say they should tell me what their epiglottis view is. Now we can see the video laryngoscope, obviously, but it's quite good to have that closed loop communication. Okay, so everybody, because you work with the team, so everybody in the theater needs to know what is happening. Team members should aim to be assertive and yet respectful. Again, it comes back to being assertive yet respectful, when communicating. Next slide. Anticipation and planning. Again, anticipation, we do anticipate. So when you've got a high-risk patient, you normally would make a plan, and that is a little bit of anticipation. For example, a difficult airway, you would definitely make a plan. You would have your video laryngoscope, you'll have your, whatever the difficult airway trolley and so on and so forth. So planning is very important. Again, that you can do for an elective case, but for an emergency, again, it may happen sort of, just out of the blue. And hence, protocols come very important there. Things like, having a flow chart for anaphylaxis. So when it happens, once in a while, the chart is there sitting on the wall and you know exactly what to do, what drugs to give, when to send the tryptase and so on and so forth. So that is very important. So by anticipating and planning, teams can develop a shared mental model, prioritize tasks, promote workplace safety. This is very wordy actually. So I don't expect you to know all these things, but I think in a nutshell, what it says is it basically makes life much easier for you and saves the patient actually when there's a crisis. Next slide, please. Resource utilization. Now, this is very important. What it means by resources, again, you're an anesthetist, you got a surgeon, you got somebody to help you. If you then need something in theater, don't send your person who's helping you, send the bloody surgeon actually, because they probably are not very important at this stage. I'm assuming actually, if it's an anesthetic, of course, if there's bleeding and you need, that's a different issue. So use the right people, don't send somebody else. So that's a bit about resource utilization. Okay, and that will change again. So it says survey continuously. You have a look what's happening and keep your key people around you actually. Don't send wrong people outside. The team leaders are responsible for this. Sorry, next one. Workload distribution. Again, I'm not going to go into details of this, but this is about, again, an example would be if somebody is doing CPR, don't let them do CPR for 15 minutes. That CPR was an hour and a half. So everyone took turns, to make sure that, and that's a bit about workload distribution. Otherwise, somebody's going to be very overwhelmed and they're going to crack. Okay, next one. Situational awareness. As an anesthetist, we talk a lot about situational awareness. It is very important, where, you're processing so much of information that you don't want to be task fixated. So in a medical crisis, having situational awareness allows teams to identify and respond to a change rapidly. So again, coming back to the last one, the obstetric lady where, very quickly they realized that this is not a high spinal, but this is something else, and they acted accordingly. Unfortunately, the outcome was not great because she had aortic fluid embolism. So, but they did the best what they could do in that situation, because even seconds were very vital for her. Okay, next slide, please. Triage and prioritization. Again, I'm not going to go into details of this, but this is for a slightly bigger event where you need to triage. What is important right now? Is the blood gas important, or is the creatinine important? Probably the blood gas. It's just an example. So don't unnecessarily send things when you're not going to look at them. So that's your prioritization. Next slide, please. Management of disruptions. This is very, very important, actually. And I've spoken about this earlier, that there are disruptions, and you don't even know as an anesthetist how much of disruptions. I mean, many years ago, I was in the simulator. This is about 20, 25 years ago, and the patient had some scenario, and I managed the scenario. We're doing arthroscopic case in the simulator, and when I went back to the for a debrief, I realized that I had not put the lights off in theater, or on in theater. So basically, I ran the whole scenario in pitch darkness, actually, with the monitor light. So what I learned there was, when there's a crisis, get the lights on. So these are the small things where you don't realize, how they could be helpful. So next slide, please. Patient safety, incident response. The PSERF. This is basically, again, I'm not going to go into details. You can read about this. I'll put links. This is the new framework that we use on if there is a critical incident in a hospital setting or a healthcare setting. How do you manage that? What is the framework around it? This is a long process, but we are adopting it, actually. And it's fantastic, actually. If anybody wants more information, please, I'll put the links in there, but we'll be happy to provide that information. Next slide. Engaging and involving patients and families. Now, this is very, very important. I think over the years, what we've learned is very important to involve the family, because we are so anxious that we almost drift away from the family if there's an incident like this. But actually working with the family helps the doctors, and also actually teaches us a lot of things. Next slide. So when you're engaging the family, again, I've just made a list of 9 things what you do. Apologize. Apologies are meaningful. They shouldn't come from the heart. There's nothing wrong in saying, I'm really sorry, this shouldn't have happened. It doesn't mean that you made a mistake. It just means that I'm sorry for what happened. The approach should be individualized. Every patient's relative or patient will be different. So it has to be individualized. Timing is sensitive. When do it actually? You don't go and apologize in the anesthetic recovery, because they won't be awake then, or they may be very upset in the first week. Go later on. Those affected are treated with respect and compassion. That's for anything in life. The guidance and clarity is provided. If they want more information, do provide them. Those affected are heard. Approach is collaborative and open, so work with them. Subjectivity is accepted. What it means is people can be different, you can be different. And lastly, strive for equity. Equity, what it means is equity of color, size, shape, age, sex, everything actually. Next slide, please. A second victim. So Bhakti wanted me to talk about a little bit of second victim. Now, we all have been a second victim in our careers, and I'm sure however short your career is, you would have felt at some stage really, really completely overwhelmed by a critical incident that you were involved in. And I think it seems there's some evidence that up to 50% of healthcare employees have had the experience of being a second victim. I've found a definition there which says, basically, they are involved in an adverse patient event, a medical error, or patient-related injury. They become victimized in the sense that their employee is traumatized by the event. Frequently, these individuals feel personally responsible, and I'm sure you've been there. I've definitely been there n number of times. Many feel that they have been responsible, they've been let down by the system. And then what happens is you start sort of questioning your own skills, your own sanity. Am I good anesthetist? Can I do this? Can I do pediatrics? Can I do obstetrics? I don't know, So what are the impact? Personal impact, you really feel shit, incompetent. Professional impact, it might affect your working relationships, it might affect your practice, I don't know, your normal practice. And it prompting constructive change. So again, it might change the way the things you do actually. Next slide. Again, what is the impact? I've just gone through those actually. The impact is terrible, and some people actually have been pushed to suicide. I know, 2 cases here where sadly one of our colleagues, who did that, again, after an incident, after a long inquiry. But most of us do recover, thankfully, actually, and that's great. And there are 6 stages of recovery, and this is again a bit of theory around it. The first is the chaos and action response, intrusive reflections. I'm not going to go into those, but the last bit is important, moving on, actually. Once you have got over it and you just move on. Next slide, please. How can you support? Well, how can the second victim be supported? Now, we've got lots of forums in the hospital, not necessarily that I go to the psychologist, but the option is there for me to use that. There are lots of online resources that the hospital provides as well, and increasingly they're being used. And you spoke about the Generation Z, actually, and they are well aware of their, deficiencies or whatever, and they will not hesitate to ask for support and be open. I think our generation is pretty poor at that, actually. So basically it covers emotional sort of first aid, local or departmental level, peer-to-peer, one-to-one support. So, you may be given a mentor or somebody to help you to come out of it, and access to professional counseling and guidance. Next slide. What is the role of, again, what is the advantage? Higher self-esteem. Again, it's self-explanatory. If you help with that, you definitely feel better and you get back to normality much earlier. Next slide. Okay, this is the support that we offer in our hospital. They're all free. Again, if somebody wants, I can give it. Again, some people use it, some people don't. So, but it's very confidential as well. Next slide. This is a bit about human factors. I've just added 2 slides. These are self-explanatory. Next slide, please. This again talks about 12 recommendations. Kelly et al. There's a paper in 2023. It talks about things like ampules. They should be, the ampules are so small these days. Just examples there. For example, we had socks and midazolam which looked the same, many years ago. And there were a couple of incidents where people gave socks instead of midazolam, actually. So it's just an example. Again, I'm not going to dwell into detail. If you want, you can pick up the slides from Bhakti, and I've put the references at the end, actually. Next slide. Oh, and that's the references. Wonderful. That's done. Thank you for tolerating me.
Thanks a lot, Sachin. Are there any questions? Let me just...
Can you put the references slide again?
Yeah, sure. 1 minute.
I mean, the PSURF is an online resource, and NHS England has it. So it's a very comprehensive document, hundreds and hundreds of pages with sublinks. But I would suggest have a look at that. If anybody wants any help with their institutes, I'll be more than happy to help, because it's one of my favorite bits in my job, actually, the risk management. So.
Okay. Can you view that? The references?
Thank you.
Yeah. I think we can open the forum for questions. Is there anything on the chat? Okay, we have a question here. How did you break the news of wrong-sided block to the relatives?
Thankfully, I didn't do the block, so I didn't have to break the news. But so basically, as the investigation said, she went to the patient and explained to the patient that inadvertently she's put a wrong-sided block, but there was no harm done, thankfully. And because the patient was old, she also went and spoke to the son of the patient. And again, when you apologize to the patients, actually, they are understanding, actually. And but if you leave it for 3-4 months and then somebody goes and tells them this was done, that's when the problem starts, actually. So you should always be honest right at the beginning. So yeah, if that's the answer that you wanted.
Also, can I add something? I think usually, because this is a part of even our OSCE and VIVA, wrong-sided block, I think it's very important to then focus that you ensure that you get adequate pain relief to the patient perioperatively, as well as post-operatively. You have rescue analgesics that have been prescribed to the patient, because what the patient really remembers is pain. So if the patient is in pain at that point of time, any sort of conversation, it's just going to be registered as something that was done wrong to me or wrong to my parent or colleague. So I think as long as you manage your required pain relief and your vitals are stable, I think at that point of time, it's just easier to have this conversation with the patient and the relative as well.
Thanks, Neil.
Thanks. I think there is one more question there. How do you decide what's the right time?
Again, there is no prescription for right time. Every case, that's what it says. Every case is different. But I think it all depends what was the incident, isn't it? I mean, something like a block. I mean, it's the patient will be probably inpatient for the next 3-4 days. If it's somebody like a day case, you may want to call the patient at a proper appointment later on. It's very, there's no prescription here. As I said again, it says it's subjective. You know what the incident is, who the patient is, who the team is, and what kind of incident most important. But you should be in a frame of mind yourself. That's very important. I mean, it's very disheartening for us as a clinician when you make a mistake. So you should be in that frame of mind. Don't hesitate to ask for help. Ask senior people around, experienced people around. When you write letters to patients, again, seek help, seek senior help. I mean, we got the Medical Defense Union. If I have a problem, I will just ask them to help me check my letter. It's very important. Help is around. You just need to, be signposted and go to the right people and the right forums.
Okay. All right. Sajjan, there's another question. You spoke about making a statement in debriefing. Making a statement in debriefing. Can you give an example? I didn't
Which
get
statement?
that.
Sorry.
Sorry. Sukada, you want to? Okay, maybe we can.
Am I audible?
Yes.
Oh, yeah. Okay.
Yeah. Actually, you spoke about the debriefing and making
Yeah.
a clear statement.
So correct. So basically, what happens is, for example, let's say that the cardiac arrest actually. So after the incident, what happens is we try and do a hot debrief, okay, where there's a quick sort of meeting with everybody involved at the end of it. And again, if I'm the senior person, I'll thank everyone for all the hard work they've done, which everybody feels better, support them, because somebody will be crying. It's a terrible scenario, In this case, a lot of people are crying actually because obstetric death, as you know, is terrible. What I mean by statement actually is this is going to be an investigation, that, okay? So when this is fresh in your mind, maybe the next day when you've recovered a bit, write a statement of facts. For example, I'm the anesthetist, so my statement of facts will be, I went and saw the patient on this day, this time, this is my pre-assessment, this is what the patient came to theater, I did this. There should be no emotions, It should be a statement of facts, what you did, what were the facts, end of the story. Because lawyers don't look for emotions, they look for facts.
Right.
Okay, thanks. There's another
Can I
one.
just add something? So usually whenever these kind of critical situations, what we usually do is, like Dr. Prabhu rightly said, we have a hot debrief that is immediately post the critical situation. All the team members involved, absolutely each and every team member that was involved in that critical situation comes in together. The team leader usually takes the sort of the forum where they discuss about what went right, sort of appreciates the fact that what were the right steps that we did. What could we have done better at that point of time? Was there some sort of delay? So moving forward, could we have done something probably quicker? Was there something that we missed at a particular step? So we discuss this. We discuss whether the family has been updated. We think of all our, sort of our next steps. And I remember this specifically because after the maternity obstetric sort of mortality, we even had a cold debrief. So usually about, say, a week later, even individual trainees, so the consultants, they actually approach us and they ask us whether we've been okay, because it can be a very emotionally turmoil situation. So even a cold debrief after about a week can be very helpful, especially since we've also spoken about Generation Z and how emotionally unstable in general, a lot of the Generation Z are. I'm not sort of saying that the entire generation is like that, but it's true. We come from the Generation Z is all about techno savvy and less face-to-face interaction. They've got less. So I think it's very important to understand that this generation also needs to be sort of, you need to cater to their emotional needs as well. So having a cold debrief after about a week, especially when you've dealt with such a sort of critical situation, can be also really helpful.
thanks, Nihal. I think there's another one. How do we develop work culture at a nascent institute that promotes patient safety?
That's a
Sachin,
great
you
one, actually. I think it's
Yeah.
easier if you're in a nascent stage. I mean, again, I think there are very set standards. There are very set protocols. There are, this is what you need actually. You should work by protocols. You should, developing a culture takes time. But if you're in a nascent stage, it's even better actually. If we hit, it's quite difficult to do it in places which have been there for hundreds of years actually, because there's a culture. But again, I mean, I'm quite happy to be contacted separately and help you with some of these things, because that's what I do for a living actually. So definitely, yeah. I can't give an answer. It's not that easy, but probably you're in the best position if you're in a nascent stage or department.
Yeah, that's true. There's another one. What's the cutoff point time of CPR in your institute?
There is no cutoff for CPR. It is the team decision. Depends on the situation. This one I think went on for an hour and a half. I don't know, even more. If it's a 90-year-old with cancer with something, we probably will do one cycle. So it's very subjective. But we want the whole team, because it's a cardiac arrest team. We will make that decision based on sort of team, because you don't want one person from the team to say, oh, well, then we'll continue. But yeah, there's no fixed time. It's subjective based on the situation and the patient.
Okay. Also, who does the debriefing after crisis is the next question.
Again, depends. Usually the senior person. So
Okay.
we'll do the debriefing, or it could be somebody from outside that team go and do the debriefing. It doesn't matter. Somebody who can hold fort and be strong and be supportive, be compassionate. Yeah.
So somebody part of the team
That doesn't not necessary. Not necessary. It could be anybody. Again, the idea here is to allow people involved to talk and as Snehal said, to sort of just let the emotions out and take something positive from this. When they go home. So anybody could. I mean, I sometimes lead debriefs as well. So it's okay. Anybody can. And we got a governance team. So there is a non-clinical person who leads as well. Somebody's trained in all these things. They're hard to get, but yeah, they can also be used for a debrief.
Okay. So even for hot debrief?
Yeah, if it's daytime, you can get somebody. That's not a problem.
Okay. All right, there's another question. Who breaks the bad news?
See, again, so for obstetric one, again, I don't know who went, but generally, if I as a consultant anesthetist will go with a consultant surgeon and meet them, because we are the two most senior people and the responsible people. The trainee is not responsible. I'm responsible, and so is the surgeon. So it is important that I show leadership. I will go and talk, but this is shared. Even if this was an airway disaster, I would still want the surgeon to come with me. If it's a surgical disaster, I would still go with the surgeon, because we are a team. It's very important that we go together. Again, that's very subjective, but that is what I would do. Yeah. I think the key here is we work as a team. So we the fruits of labor are as a team, and if it shit hits the fan, it's as a team.
Yeah,
Right.
I think I completely agree with Dr. Prabhu. I think we've always given a lot of importance to multidisciplinary team approach right at the beginning, even when we start off our cases. So I think every step of the way has to be sort of a team approach. So even when you approach the patient or the relative at the very end, we try and have it as a team together.
Yes. I guess that makes sense. It always should be we rather than, he or she, even while breaking the bad news.
And one more thing we've often observed this, that for example, if the anesthetist team approaches the patient separately, and then the obstetric team probably approaches the patient separately, what we've seen is often they have questions that as an anesthetist, I could probably not answer, and probably the obstetrician could not answer some of the questions which they have regarding anesthesia. So when you go together as a team, it's just easier for even the patient to process the entire information and then sort of ask all the questions in one go. And I think it's just easier for the entire team as well as the patient and the relatives.
Sure,
I think the same holds true for the planning as well. So if I expect a problem, so for example, I did a 98-year-old with every possible problem in a heart, lungs, kidney, for a neck or femur, needs to be done because for pain relief. Then I went with the surgeon and spoke with the family so that we are on the same page, what he's doing, what I'm doing. So, so even in your planning, it should be a joint one if you have the time.
Yeah,
Because
absolutely. In
relatives
fact,
always say that patient was talking, she was fine. How did she die? For them, every patient is fit. Whereas for you, you know that just being talking doesn't mean they're fit actually. So it's important to do that at the start.
also, I think one more thing I'd like to say is that like we're giving a lot of importance to debrief. As a part of WHO checklist, we also have a team briefing. So at the very beginning, so for example, even if I'm a part of a theater list, at the very beginning, once we've seen preoperatively all the patients have been assessed by the anesthetist and the surgeons, we have a team brief wherein the anesthetist, the surgeons, the ODP, the staff nurse, all of us come together and at the very beginning sort of decide probably if you want to change the order for whatever reason. Say there's a patient who's high risk and you would probably like to do the patient early on. So you have this discussion very early on. So again, a team briefing at the very beginning, wherein you again have checklist available. And I think that is also really helpful.
Right. Thanks a lot. So obviously a dialogue is always very important, whether it's pre-anesthesia, post-anesthesia, during crisis, dialogue between teams, dialogue with the patients, with the relatives. With that, I would also like you to invite to this one-day CME that we're going to hold very soon, the next 2 weeks, called Dialogue. Thank you very much.
Lovely. Are we done?
Yeah, Yogita?
Yeah, I am there. Amla madam, are you there? You want to add something?
Hello, Sachin.
Hello, madam.
Actually, listen to both the lectures quite well, and actually, some of the questions were put by me. And it is really nice session. We hope to have similar sessions in future. And whenever you come here, I would like you to do a session for our residents.
3 weeks
And for
tomorrow.
Yes.
At
He's
your
on his
service,
way.
madam. So I'm at the airport tomorrow. I'll come and see you, madam. Definitely. I just want to say that for the Generation Z, I'm madam's first student, by the way, Generation X. So
Oh, okay.
Okay, so I guess we can wind up the session. I thank Amla madam for giving us the opportunity to choose this innovative topic. I thank Deepa madam, GC member SAMS for joining for this meeting. I really thank all the senior members from different city branches of Mumbai who have actively participated in question answer sessions as well and made this discussion really interesting. I thank Dr. Prabhu and Dr. Kale for the excellent presentations and giving some inputs, which we are still adapting to all these changes. So really looking forward for the way Amla Madam has told for future interactions and maybe inputs for setting us into this departmental things for teaching institute especially. I thank our Gen Z, Yogita, Himaja, and Chandini for their inputs and wish to incorporate the changes which they have suggested can be, utilized to make them the interesting sessions more interesting for them.
Be the
And I
millennials.
thank, yes, ma'am.
Yogita and all must be the millennials.
Yes, yes, millennials.
Gen Z is not watching this program.
I thank Ganesh and Sams for giving us this platform for conducting this webinar. And I thank all the delegates for making this session interesting. So thank you so much, everybody. And we can say goodbye.
Yeah.
Thank you,
Thank
Dr.
you so
Prabhu, all the
much.
way
thank you very
for
much.
joining
Thank
us from
you.
the airport.
Thank you. I better miss my flight now.
Thank you so
Thank you
much
so
for
much.
this
Take care.
opportunity.
Bye.
Thank you.
Thank you.
Bye-bye. Thank you.
Hi, Snehal.
Hello,
I'm
hello, Dr. Amna ma'am. Hi.
seeing you after many, many years.
I know, yes, yes. It's so good to hear from you.
How are you?
Good, 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 ma'am. Very
Yeah.
good. Much better now. Yes. Thank you.
Yeah.